as Sue Henry is one half of our Women in Leadership Special Interest Group chairing team, and she's here to introduce Lisa Knight's session, because this is a session focused specifically as part of our Women in Leadership Special Interest Group content. And there's also a session later on in the operational management stream delivered by Amanda Reynolds as well, about fostering female talent. Sue, would you like to introduce Lisa, please?
I certainly will, and sincere apologies that you have an image of me as opposed to myself, and I don't know what's happened there, Jade. So anyway, welcome everybody. I'm delighted to have been asked by Jade to chair this session and introduce Lisa Knight, Head of Centre for Management Development at John Moores University, and also a non-executive at Mersey and West Lancs NHS Trust. As well as being co-chair of the Women in Leadership Group, I also have my own small business, Sue Henry Coaching / MSH Partnership, having worked in the NHS for over 25 years until 2012. So I'm delighted to welcome Lisa. Please use the chat box function. I will keep my eye on it for comments, reflections and questions, and we'll have time at the end to explore some of those with Lisa. So thanks, Lisa. Welcome, and over to you.
I'm gonna share some findings from some recent sort of research I've done with integrated care system leaders. I'm gonna share mostly from their voice. I'm going to try and share lots of kind of quotations from the leaders that I spoke to. I'm going to draw out some of the key findings, and hopefully that will be of practical use and also resonate with some of you in those leadership roles, but certainly help to understand some of those challenges, some of the contexts and complexities, hence the title. But you'll note I've put my email address on this slide, and that's because I'm really keen for people to get in touch, and I'm always happy to explore and discuss this topic and hear views and really understand how practice is being developed and leadership's being developed in this context. So let me there we go. So you all know about integrated care systems, and I guess that interest in their use and purpose has been growing within the last decade, but culminated in the formation of the integrated care systems in 2022. And that's when my research started. So it's focused on working with leaders of integrated care systems and understanding the challenges that they faced and how they were addressing those, really. And before I get into sort of some of the detail around it, what was really, and what's continuing to be important in integrated care system leadership is the legacy, I guess, of the health and social care differences. So the differences between bringing together two different sectors together, and the post-pandemic legacy, neither of which will come as a surprise to you, but I'm going to talk a little bit about these, really. But really the sort of tension between the relationships between different partners within the ICS, the challenges that presents to collaborative working, the impact of the pandemic in terms of requiring an immediate sort of crisis response, but that health and social care have moved into a chronic phase of sort of managing these compounded pressures of the pre-pandemic issues that already existed, that's been compounded, where leaders are sort of struggling to balance the immediate patient care and user care needs with long-term system work. So, and as I said, what I've tried to do is get the voice of leaders through. So I'm not going to read out the quotations that I'll leave on these slides, that you'll have access to these, and also I hope you can read them as I'm talking along. But what I want to do is just pull out the leaders really identified the ongoing impacts of COVID-19, that it was impacting on planning and delivery, and very often the negative aspects of the pandemic were highlighted. So, you know, the impact on waiting times and backlogs, staff morale and high levels of stress, alongside obviously the impact on communities in terms of mortality and morbidity and so on. But also importantly, they highlighted the increased collaboration between partners during the pandemic. So, and that influencing how relationships are developing. So there's something really important there about the kind of history and the previous relationships that people are drawing on. There was I think some of this will resonate with you, but the differences between the health and social care systems in terms of regulation, in terms of funding, financial regimes, the ability of the NHS services to forecast a deficit budget, and social care services not able to do that, and that kind of creating tensions in terms of long-term planning, and working together to overcome those immediate post-pandemic issues. And you see there, you know, I mean, one really interesting point, you know, that somebody from the NHS made, you know, local authorities will only consider us as partners once we get our act together on finance. So what I've done is I've tried to, for those of you that are familiar with the NHS North West Leadership Academy, you'll know that they have a framework for leadership behaviours that are focused around 4 areas of being, leading and visioning, relating and communicating and delivering. So I've tried to for ease pull this together within that framework. So starting with this idea of what does being a leader mean, and how does that influence leadership decisions and activities? When I talked to the leaders, one of the things that was prevalent and, you know, forefront in everybody's mind was this idea of a sense of purpose, purpose guiding actions and decision making, and that purpose being to improve the lives of communities that we serve. But what was really hard and what was really kind of challenging for leaders was being able to really kind of focus on those patient and resident issues when we're continually pulled back into the kind of day-to-day in terms of those immediate issues that we're facing in the system, like access, financial pressures and so on. So that need to keep being pulled back into, you know, pulled towards the values and the purpose. And I'll share in a moment, but one of the ideas around, you know, use of patient stories, resident stories, and presenting sort of real world impact, so people could focus on the purpose of decision making, when often, you know, the focus can be drawn towards, you know, those sort of finances and access issues. There was a real sense of a need for psychological safety, a need for that idea that mutual respect, challenging conversations, trusting that failure would be seen as a learning opportunity, supporting people to take calculated risks. And so in relation to that, the aspect of being a leader, I've tried to summarize there from the quotations and all of the kind of discussions that we had. But this idea of patient stories really provides an important means of connecting decision making to the experience of care. When we have challenging conversations around outcomes and around purpose and delivery, that supports partners in this development of a psychologically safe environment where there's a level of trust and acceptance. And again, similarly, this sort of taking calculated risks together. So collaboratively focused on longer term outcomes, and supporting each other where there was a, you know, potentially what we might deem a failure, or kind of focusing on the learning opportunity there. And then when we think about leading and visioning, so this idea of vision was really, really important. all of the kind of caveats around organizational differences, cultural differences, and those being barriers to partnership working, the idea of having a vision that everybody worked towards was, really, really important. There were challenges in being able to realize that vision, and particularly the sort of fragmented nature of our current health and care system. Sometimes, we're not really helping integration and decision making. We're moving from multiple organizations in a system that's quite stretched in terms of finances, and that sometimes that can lead individuals or organizations to sort of entrench and sort of silo their behaviors rather than working in that collaborative approach that we'd like to see in integrated care systems. I think one of the things that was really interesting, we talk about sort of clinical and care professional leadership, and there was quite a lot of emphasis a lot of understanding and willingness from leaders around that, and a commitment to investing in that. But actually, that was quite limited. And where it was there, it was very much focused on, I guess, clinical leadership rather than care leadership. So, health being the kind of dominant sort of partner in that leadership aspect when we came to clinical and care leadership. So there's and again, try to summarize here, real need for shared vision amongst partners to help focus on priority setting and decision making. A need to move away from siloed thinking and that organizational self-interest in order to address those system-wide challenges around population health. And that the governance structures that we currently have don't really support clinical and care leadership. And we know that clinical and care leadership can facilitate more effective collaboration, and it can support peer engagement and that wider kind of engagement of the workforce. And then a little bit, about this idea of relationships and communication. So again, trust came up as really, really important. Trust between individuals, trust between organizations. So there's something about really fostering those relationships to build trust over time, which again, I think relates to what their experiences of having historical relationships and drawing on those through the pandemic. But there was a sense of that really starting to emerge. So I started this work in 2022 when the ICSs were formed, and it was a 2-year piece of work. So just recently come to an end. So I think over those 2 years, an awful lot of experience and development, I guess, in terms of the leadership. So trust and shared commitment, really important for those strategic partnerships. But people felt that they're starting to get a grip on that, really. It's also really key, and I think something that we need to collectively as a community explore, is the idea or the perception that the NHS were the dominant partners within integrated care systems, but also that local authorities were the big brother or the dominant partner, I guess, around the voluntary sector. So there's a whole thing about how we work together as individuals, individual organisations, to get that equity across the system in terms of leadership. Again, similar really, but the community and public engagement. So we talk about having community voice in all that we do, but I found that there was real willingness to do that and a real intention and desire to do that, but actually significant gaps really in how we effectively engage with the community. The current approaches that we esse aren't particularly helpful for fostering constructive dialogue. Sometimes it's very much like speaking to rather than speaking with. So, more work to do around genuinely incorporating the public's voice into decision making, which is a key function of the ICSs, as you know. Really important around the wider workforce and the pressures that the wider workforce are under. As we all know, increasing need for efficiencies, there's staffing changes, recruitment gaps, challenging working conditions, and an increased demand for services. So all the leaders sort of recognise the value of engaging with the workforce through comms, direct contact, or specific initiatives to support wellbeing, in a similar way that some of our colleagues were speaking about this morning, and that unsurprisingly fosters a sense of inclusion, value, and therefore increasing morale amongst the workforce, that wider workforce. And again, I've tried to summarise that here. So really importantly, that idea of the history between partners, that we need to consider our engagement and integration of community feedback into decision making at place and local communities, in neighbourhoods, and move away from those perceptions of tokenism. And unsurprisingly, leaders needing to be visible. But I think trickier in larger disparate organisations across a whole area, and I'd be really interested in people's experiences of that. And I'm hopefully going to give us some time to have a conversation about that as well. So I'd really value everybody's input. And then lastly, this was delivering, is really around this idea of what does the structures look like for, delivery and governance. And I've mentioned this before, but it was really important, the dual pressures of maintaining operational stability whilst at the same time trying to encourage service delivery, innovations and improvements. Identifying, the leaders identified that exploring innovation or implementing any kind of large scale change was risky and uncertain. It didn't feel that was something that was able to happen in the current system. The operational challenges sort of highlight increase their perception of the risk and uncertainty. So there was reduced innovation and improvement across the system. And similarly, the idea of we've got limited resources. So how do we identify where the greatest need is for those? And the leaders all felt that was really important. And there was this sort of focus on using data to understand health determinants, developing proactive care models, focusing on groups of individuals at greatest need, reducing health inequalities. But there was mixed views, I think, around place governance. So as you know, we've got the integrated care systems, and then within those places and neighbourhoods, and that there was sort of mixed views there, really. There was probably some desire to move the decision making and financial resources to the more local level, to place, but that was felt risky and challenging to sort of some of the leaders, and that wasn't something that was happening quickly. Which links to, I guess, this idea of the tension between our kind of historic focus on acute care and the intended outcome of ICSs to move towards improved population health. And there is still that tension. So these financial allocations and the operational pressures being barriers, and so at the moment, my view is that we're reinforcing a sort of reactive health and social care approach rather than the intended proactive approach of integrated care systems. And that we need to move, one of the ways to move away from that is changing the performance metrics and the funding flows. So, the system's capacity to plan for and implement these population health strategies is improved. But so then there's again the key sort of summary of some of those elements I've just talked about. So the lack of delegation of budget obviously limits the community's ability to respond to need. And this is the summary that I pulled together in terms of what being a leader, an effective leader in an integrated care system looks like. I hope that the conclusions from the research offer sort of practical recommendations for leaders in integrated care systems. There's much more work to do there. I was fortunate to be able to share my findings with the recent Health and Social Care Select Committee that focused on leadership, and I hope that that we can explore the role of leaders in ICSs and try to improve a bit of practice. I'm aware that I didn't include wider workforce experiences, and I'm hopeful that I can move that forward and try to access those in the future. But I'd love to hear people's sort of experience and whether any of this has resonated in terms of being a leader or being part of a leadership community. And also, I didn't include patient or community perspectives, but again, I think this would have enriched everything. So, right, I'm going to stop sharing because I'd really love to hear people's thoughts, and I can see hands up as well.
Yeah, thank you, Lisa. Thank you very much for that. I found it really interesting. Just very quickly before we take Chris's, Chris has got his hand up, and so as Tom, having left the NHS in 2012, but continued to work with it and across in various capacities, that some of those reflections and some of your research actually, it's been there quite a long time, so it's nothing kind of new. But one of my other thoughts when you were talking initially was that we kind of got together around a common cause or a common enemy in COVID, and actually then that helped, strangely, that helped things move forward and develop relationships. So it is interesting. So, but I will take some questions for you. And so Chris, how can I please come in?
Thank you. Can you hear me okay?
Yes.
Lisa, thank you ever so much for your presentation. I might drop you an email, actually.
Great.
My background's a senior manager in the NHS. I've also been a lead governor for a foundation trust where I had a foot in the community and a foot in the NHS. I'm currently chair of the board of trustees at Kettering Mind and have worked quite a lot with the VCSE sector in, if you like, public engagement, also community engagement. I set up a one-stop health and wellbeing information shop next to Boots in the High Street, where we offered reflexology, Indian head massage, freebies, and people were coming in for help in terms of prevention, early intervention and signposting. And what was clear to me post-COVID is not only was it about prevention, early intervention, signposting, but it was also advocacy. And that was whether it was a colour of people's skin, whether it was disability, whether it was a whole range of issues. People just don't know where to go. And there is a huge disconnect, in my opinion, between what ICSs say they're doing and what they're going to do. And I've worked in the NHS, I've worked with clinical colleagues, consultants, many levels and different backgrounds. And there is, if you like, as you said, it is very heavily controlled, managed, regulated. Local authorities, you've got even a different dynamic with elected members. But in the VCSE sector, what I found is people have to trust me before they trust my message. And yet, what we've been able to do is far more innovative. Things, if you like, are organic, they're fluid, they evolve, but they're based on relationships. So your whole point about these inherent tensions, which you articulated very well, in my view, the nuances of which are subtle but sophisticated. Yeah. And I think we've got a long way to go. Last year, I set up a new test and learn delivery project funded by the ICS, which was through the VCSE sector, working with the NHS and social care. And that was to do with issues around tackling poverty, because we all know that only 20% of what makes us healthy comes from healthcare. 40% education, income, community safety, psychological safety, health behaviours, the other 30%. I could go on. I'd love to be get in touch with you, if I may, just to share some of those experiences, which I have at a direct level. And on a positive note, we work with the NHS locally as Mind in providing crisis cafes and diverting people away from A&E, staffed jointly by mental health navigators and our own staff. And we also provide courses for depression, anxiety, a whole range of support for people who are struggling with their mental health. So thank you for your presentation. Thank you for allowing me to share something of my own experience. Sorry to dominate the Q&A. Sorry, looking at the time, but I will drop you a note. Thank you ever so much.
Thank you, Chris. So I'd love to hear from you, because that would be great. You're absolutely right. And I think, ICS leaders are in a tricky position in terms of that tension of, what's coming centrally in terms of their regulatory demands and the financial pressures and so on, but there is a real need. It's never going to achieve its outcomes unless we start moving that shift towards, as you said, the 80%. So thank you. I look forward to hearing from you.
Thanks, Lisa.
Thank you.
Tom,
Thanks, Lisa.
Did you have your hand up initially as well?
No, I was just applauding. I did the little emoji for applauding because I thought it was fascinating and revealing, and there were some great comments in there. You always get, when you make time to speak to people, don't you? You always get those comments, those observations that come out that you would never see in a formal report. On a slightly different note, Chris, I think it's interesting. So I did 5 years as a chairman of a local carers association, and the third sector I found was having to adjust its style to the style of the public sector. And from setting off with what I would say were incredibly well-meaning objectives, what you found was that the third sector was being asked to do more and more for less and less. And it became more and more about ticking the boxes. So rather than the third sector being able to have that influence perhaps on the public sector and certainly the NHS to soften the hierarchy and to soften that focus on KPIs and targets and all those other things, it was kind of getting sucked into that game because that was the only way to secure its funding. But no, that was fascinating. Thank you for that, Lisa.
Thank you.
You're very welcome.
If anybody has any further questions, please pop them in the chat box, or we'll make sure we get people Lisa's address, email address again. I've just got one kind of reflection or question, really, Lisa, and you may not have picked this up in your research, but how do you think we can perhaps foster and develop more female leadership in ICSs? Did you come across anything in your research that may have some reflections on that?
I mean, not directly. I think there's it comes back to that sort of, Tom made the point about the voluntary sector being pulled into the kind of a style of working that the public sector utilise. There's almost a similar, with a male-female leadership styles there, isn't there? That's sort of what's the dominant leadership style, and we kind of, expect people to fall into and adopt that. I hope in all of those, in all of the kind of the partners and individuals leadership, that the ICS is really, we take it as an opportunity to move away from business as usual and doing something in a slightly different way. So no, I didn't directly ask around female leadership, Sue, although it is something of interest to me as a female leader. But
Yeah. Oh, thank you. Thank you so much for that. Can I just check? Will delegates be able to get copies of Lisa's slides as well? I see Jade nodding. Yes, thank you.
Thank you. And just to say before I go that obviously that was just a snippet of what I found and what people shared with me. So please, if you want more information, just please feel free to get in touch, and I can share particular aspects.
Okay. Thank you, Lisa. I found it absolutely fascinating, Lisa. Thank you.
Thank you.